Good morning, good afternoon, and good evening, everyone, wherever in the world you may be joining us from today. My name is Francesco Del Carpio, and I am the CFL York Operations Coordinator. I would like to officially open the first 2024 session of the Emergency Management in Hospitals and Healthcare Speaker Series, presented in partnership with the Thunder Bay Regional Health Sciences Center with a land acknowledgement. We acknowledge and recognize that many Indigenous nations have longstanding relationships with the territory upon which our campuses are located that precede the establishment of York University. The area is known as Tekaronto and has been caretaken by the Anishinaabe Nation, the Haudenosaunee Confederacy, and the Huron-Wendat. It is now home to many First Nation, Inuit, and Métis communities. We acknowledge the current treaty holders, the Mississaugas of the Credit First Nation, and that the territory is subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. As this is an online event, our participants may be joining from various locations, so I strongly encourage you to learn about the traditional land upon which you are located. With this, I welcome our moderator, our speakers, and our participants from around the world. Welcome to our webinar. Without further ado, it is my great pleasure to introduce our moderator, Misha Richard. Misha Richard is the current Emergency Preparedness Lead for the Thunder Bay Regional Health Sciences Center in Thunder Bay, Ontario, Canada. In this role, she acts as a subject matter expert assisting with the development and maintenance of emergency management governance, training materials, and exercises. Misha also volunteers as an editor for the Canadian Journal of Emergency Management and is happy to be a collaborator and facilitator for the CFL York series. She holds a Master of Disaster and Emergency Management degree from York University and bachelor's degrees from Western University and Brandon University in the focus areas of political science and disaster studies. Misha, thank you very much for moderating today's session. The floor is yours.
Excellent. Thank you very much. So first, I'll start off by saying we have a lot to cover today. And to start off, I'll give everyone a little bit of an introduction as well as some housekeeping, of course. I don't want to speak too soon and say maybe we'll go a couple of minutes over today, but we'll see how many questions we end up with. So I'll appreciate everyone's patience when we get to that point. So to start off with, general housekeeping. As Francesco said, the chat is open, so you can carry on sort of communal dialogue in there. However, if you have actual questions for any one of our speakers today, please populate them in our Q&A. So I'll be moderating that Q&A. We'll take a couple of pauses so that we'll be able to ask some of the, address some of those questions, pardon me. And then we'll provide some time at the end of both of our speaker presentations today to kind of wrap up and generalize so you can ask questions to whoever you would like. So to start off, I'm going to share my screen and we're going to jump into the topic today, which is Code Gray, focusing on infrastructure loss. So give me 1 second and I will get that up on the screen. Okay. So hopefully everybody can see my screen right now, which says Code Gray Introduction, Emergency Management Hospitals and Healthcare Series. So I'll start off. So some of you, if you have joined some of our other sessions, have seen me give this really quick overview history. I know this is Canadian and Ontario specific. Other organizations might be going with some differences here, but I like to provide this every time as just a part of that general overview that a lot of us are singing off the same song sheet here. So to start off with, the Ontario Hospital Association ended up endorsing this series of emergency color codes that you see on the right-hand side of the screen. Today, we're going to talk about Code Gray, and you'll notice there's 2 different Code Grays that get highlighted here. One says infrastructure loss or failure, and the other one says button down, external air exclusion. We're not going to talk about button down at all today. We're just focusing on infrastructure loss or failure and one particular mode, which I'll get to in a second. So the goal by having this common set of color codes was to basically reduce human error. So if we know that these are the general codes and this is what it means, if that gets announced or gets emailed out, any communications on this, again, we have a general understanding of what each one of these means. And if people are working between different hospitals, they'll know that it should be similar at each one of those hospitals, if not exactly the same. And then, as mentioned, these codes were also endorsed Canada-wide in application. So what is a Code Gray? So it applies to instances where the hospital experiences a significant unplanned disruption or loss of essential services like a utility, hospital building, and basically exceeds the ability of, the hospital and their different departments with what we refer to sometimes as downtime plans. Some of you might think of that as being more business continuity related. So having some of those plans underneath to kind of support what you would do if there's an actual emergency loss of one of those pieces. So what might this include? Physical building structure, so maybe a breach of the roof or a flood, those often get put into this category. Although I will comment that some hospitals have a separate code for flood depending on, their geography and the frequency of those incidents. But many of us have that included under infrastructure. Network infrastructure, and that's what we're going to talk about today. But network infrastructure and then building systems. So this could include access control systems. When you think of swipe access and getting, security in and out of a facility. Air conditioning, these are in alphabetical order, not in order of significance. Fire protection systems, heating, medical gas, overhead paging systems, power, sewer, ventilation, water. And then as said, we're going to talk today about network infrastructure. So again, just want to highlight there's some variance between what we categorize under this between different healthcare facilities. Some folks might include a disruption or loss of mobile phone networks. At my facility, that doesn't automatically constitute a code gray infrastructure response, but it might still actually require our organization to get an incident management team together. So part of that might depend on what mobile network your hospital and staff are most connected to. So just putting that out there. And then, so what's a network code gray? So this applies to instances where there's a significant disruption or loss of the hospital network, whether by accident, so if you had an equipment failure, or malicious means, something like a cyber attack triggering the loss of the network. And when this occurs, there's a variety of different systems that are impacted. So again, some of us do things a little bit differently. So at my organization, we consider network loss to be a part of code gray infrastructure. Some organizations have actually categorized loss of network as a separate emergency response, sometimes called code beige. So if you hear that, that's what that's referring to. And then, so basically, what's going to be impacted if you have this network loss? So to really give everyone an overview before we go into our two speakers this afternoon, is it can include all of the following. Again, it varies between different instances. This isn't meant to be an exhaustive list. So software applications and functions. So having your health records systems, meal planning, payroll, your email, even your printing, all of that can be tied into the network and can be impacted or lost entirely in one of these scenarios. Obviously, that would include potential Wi-Fi access if Wi-Fi is being provided through your organization's network, as well as remote access. So when you think of staff that are working from home and are on VPN, they're going to be impacted by this loss. Telemetry systems, internal phones. So in my organization, our kind of core phone system is directly connected to the network. We do have some backup phones on separate lines, but in general, the majority of our phones, they're all things that are plugged through this network. It may include security cameras. So if the network goes down, you're going to lose your CCTV. It might include things like your parking system. So you can see it's so varied, everything from, medical records to paying your staff to people being able to get in and out of the parking lots can all be impacted by losing the network. And I'm not going to ramble off about this because I don't want to bore you all, and I only have a couple of minutes in total to give you this overview. But I wanted to just touch on the fact that we have updated accreditation standards in Canada. Do they explicitly say the words code gray? No. But we can look to section 3.1.4 for anybody that's interested, that's going to see where it potentially ties in. So this is a lot of text. I'm not going to read it all. This presentation's recorded, and anybody that's in Canada is going to be able to reference this set of lists. But for anybody that's external to Canada, you might have your own accreditation standards that are similar. Otherwise, we can consider this to be in general some best practice. But you'll notice that it'll talk about that you need to be able to kind of determine prioritization of these critical systems, and that's going to include the loss of systems like telephone, faxes, mobile phones, pagers, intercoms, all that sort of stuff that would fall under this network loss that we're talking about. And then also at the bottom, there's a bullet there specifically talking about technology-based systems, so our electronics information systems like health records. We should have plans to address backups for these. So why are we doing this? Why are we having this presentation? Because these are in the news constantly. Whether it's a security breach, some sort of cyber attack, whether it's something that is directly related to our organization's network, or the example there in Australia where it's a provider that's having issues, whether it's an infrastructure failure, a software update gone awry, these things consistently happen. Just a quick scan of the last couple of months is showing a number of these. So that's the end of my intro. And I wanted to be able to give that again as just an overview before I introduce our first speaker. So I don't see any questions in the Q&A at this point, and I don't expect them to be, but I'm certain you'll have some after our first speaker. So I'll start off by thanking Karen Denise Sear for being with us today. Greatly appreciate her expertise, being able to join us and share her experience. So I'll tell you a little bit about Karen. So in her role as the Provincial Director of Emergency and Continuity Management with Shared Health Manitoba, she leads a program team that works in partnership with interdisciplinary clinical programs within shared health, regional health authorities, as well as leaders in municipal, provincial, federal, and non-governmental health and social services agencies to provide, to ensure continuous provision of health services during emergencies and disasters. She is engaged in projects impacting workforce, finance, logistics, operations, planning, communications, change management, and risk management across acute community and long-term care, healthcare settings, and provincial services. She also has a deep familiarity with not-for-profit sector organizations and community engagement, having volunteered and worked in emergency management, volunteer management, and other capacity building roles in a number of community health and social service organizations. Karen's a champion of employee wellness, engaging employer and union leaders in co-creating well-being initiatives, including critical incident stress response, trauma-informed leadership, and peer support programs for first responders. She's a human leader who seeks opportunities for teams to collaborate, innovate, learn, and grow. She is particularly proud of her ability to cultivate a team culture built on a foundation of trust, inclusion, accountability, and compassion. Karen's currently pursuing her Master of Arts in Leadership with a healthcare concentration at Royal Roads University. She holds a BA from the University of Manitoba and a Certificate of Emergency Management from the Justice Institute of British Columbia, as well as an Associate Business Continuity Professional designation from DRI Canada. A fan of live local music, Karen has also served as a past board chair of the Winnipeg Folk Festival, and in her spare time likes to travel with her family and friends to attend music festivals across Canada. She's also married, has a son and daughter, and proudly calls Winnipeg, Manitoba her home. So without further ado, I get to flip it over to you, Karen, to talk about your recent experiences.
Thank you so much, Misha, for your very kind introduction. That was a long one. My apologies, everybody. It didn't look that long on paper, but it sure sounds like a lot. And it's humbling to be able to be here today and share what I know about this topic with you from our lived experience. It's really exciting to be a part of this series. I am coming to you today from Winnipeg, and that is also known as Treaty 1 territory, the original lands of the Anishinaabe, Cree, Ojibwe Cree, Dakota, and Dene peoples, and it's also the homeland of the Red River Métis Nation. It's my pleasure to share information about our response to a province-wide digital network disruption that we experienced in October of last year, and some of our observations and lessons learned from it. And Francesca was kind enough to share my slide deck, so if you go to the next slide. Excellent. So a little bit of an outline of what I hope to cover. My goal is to leave you with a few key reflections from our experience that will, I think, hopefully be of some value to you as you prepare for a similar event in your own healthcare organizations. I'll just very briefly touch on a little bit about shared health, who we are, so that there's some context. I'll provide an overview of the event, the impacts that we experienced, how we responded, how we recovered, and some identified opportunities for improvement and mitigation so that if and when this occurs again, perhaps the impact won't be so great. Next slide. So shared health, who the heck is shared health? Well, shared health leads the coordinated planning and integration of patient-centered clinical and preventive health services for Manitoba as a province. We are also a deliverer of provincial health services and centralized business functions that support that care delivery across all Manitoba health organizations. So in the box to the right, you can see all the different points of provincial services that fall under shared health, including diagnostics, pharmacy, our EMS, emergency response services, the digital, which we're going to focus on today, mental health and addictions, some of our admin services that you can see there, quality communications, and we are deliverers of care out of Health Sciences Centre, that is Manitoba's provincial hospital. Shared health staff are located across facilities as well, province-wide, and within those organizations and our cancer authority and the locals are listed below on the slide. So it's a complex environment. It's not one site, it's potentially any site, and it's all provincial and more centralized than some of our services get to support broad. There's, in some respects, some would say less redundancy. So it's interesting. It's an interesting environment.
Karen, sorry to interject. We're hearing a little bit of that underwater sound. So the suggestion we have, even though we've got Francesco sharing the slides, is perhaps if your camera is off, it might reduce maybe a little bit of the additional bandwidth. Okay. Not sure. It's mostly clear, but every once in a while we start getting a patch that isn't quite as clear. So just wanted to acknowledge that since that was coming up in the chat, and hopefully this resolves it. But sorry to interrupt the flow of your presentation, Karen.
Can I test it now? Does it sound any better?
You sound loud and clear to me.
Okay. All right. We'll give it another whirl. My apologies, everybody. So I'll ask Francesco to go to the next slide, please. So an overview of our event. On October 19th at about 5 in the morning, access to our critical digital shared services applications province-wide had intermittent access. So as people were starting to log into the systems at the start of the workday, and as that traffic increased, the systems dropped while in use. Users were reporting that they were experiencing connectivity issues that was affecting their ability to launch or log in or use Outlook and various provincial network applications that are Citrix-based. Webmail users weren't affected. Teams was still operational, both web-based. So we knew that this was a network issue. Initially, our patient care didn't seem to be quite as affected as the health authorities did have access to applications intermittently. And so they went into downtime procedures and were able to continue their work. However, the risk to the length of time that operations really could be maintained using those downtime procedures while still needing to continue to deliver services really did become quite a concern to us. The total downtime for this event was approximately 34 hours. So it certainly exceeded our recovery time objectives for applications that are normally around 4 hours total. The final testing of all of the applications, had to continue on for a number of days, but there was full restoration and validation about 2 days later. So the good news is that our digital shared services team are very confident that this was not a cyber security attack or incident, which, I know that it would be exciting if this presentation was about that, but the reality it wasn't. It was actually related to the deployment of some vulnerability management agents that were being pushed out to our workstations. So kind of a wah-wah. No, it wasn't that, but it was just as impactful, we think. All right, so I'll ask you to go to the next slide, please. So this is a list of the many impacts to our clinical and business applications, nearly 20 of them included. So you can read through this list, but I'll just give you kind of a bit of a rundown of some of the highlights. Manual downtime procedures were implemented, as I mentioned earlier, to minimize impacts to patient care. And, we knew that one business day might be workable, but extending into day two would have really have compromised our operations. The highest impact was to the communication between staff, given that we are so reliant upon email as a primary form of communication, and Outlook was just, not working. Home care services also had significant delays due to minimal access to their electronic home care record. So what this looked like for us was that there was no ability to schedule client care. So healthcare aides, nursing, there was no ability to complete assessments. There wasn't an ability for staff to be able to access client records for important information like their medications, their diagnosis, their contact information, etc. They couldn't document their care into the electronic record. People didn't know what their assigned shifts were. There wasn't a way for people to enter in sick calls, vacation. This, in a broader systemic kind of perspective, delayed hospital discharges and planning. It really impacted our leaders' ability to even return customer complaint requests. So having the data to be able to respond to concerns and complaints, and it really took away our ability to be able to notify clients and families of any scheduled changes, which of course started to pile up as it was more and more difficult to deliver care. And kind of an odd, curious thing, and we're still really trying to figure out how this even occurred, but one of our acute care sites within one of our parts of the province, their Honeywell system went down. And we're still scratching our heads around that, but it was attributed to this event, and yet other systems weren't. So we think that there might have been gremlins at work here, but that is kind of the big picture. The other thing that really was also challenging for us was our labs and requirements that they had for completing requisitions and not having enough manual supplies on hand to do things. So, I mean, it was kind of mitigated with some supply, deliveries from outside of their area. But in the big picture, the hardest hit were very vulnerable clients in our community and our own staff being able to communicate with one another. Next slide. So in response to this incident, our digital shared services team deemed this a critical event. The cybersecurity team was activated immediately to begin investigating if this was a cyber attack. Our digital shared services focus was on determining the root cause of this event and to try and restore those digital applications. What they didn't have time for was really to help manage the overall impacts of this outage. And so they requested that Shared Health Emergency Management on call activate a support team to help do that work. Interestingly, our incident command system was not activated. However, we essentially behaved as though we were in incident command. We had 3 operational cycles with team briefings occurring to support the response, and the participants in that team were leads from our digital shared services group, communications, corporate communications, and each administrator on call within each of those health authorities. So they're designated executive lead that could make decisions on behalf of their own organizations. And they internally also then would have potentially have activated incident command to respond to the operational requirements. They, to our knowledge, only one sort of discussed it, but otherwise it was just informal briefings and then information sharing up at the provincial team level. A situation status leader role was activated to support myself as our incident director, and issues and actions were tracked and communicated via Teams. So interesting, we had to be very careful about what was being shared on Teams, given that it's not via compliant, but we were able to, in most circumstances, communicate what was necessary via Teams. And that was interesting because not everybody, believe it or not, not everyone utilizes that on a regular, but we demonstrated the value of having web-based applications outside of the network in circumstances like this. We also then had to cascade a whole bunch of notification and communications. Obviously, our Chief Information Officer and our CEO were notified. We notified the Deputy Minister of Health. We didn't know how long this was going to go on, but it could have been pretty nasty. Our administrators on call for all of the different parts of the healthcare system were notified by phone. This was incredibly time consuming. And although we have some very cursory basic mass notification systems in place, they aren't utilized routinely, and these contact groups weren't put into it. And part of that is that we're actually in the process of trying to obtain a new mass notification and emergency management software solution, which would be not network-based, but web-based. Staff were notified, interestingly, by email of the downtime procedures. And when we pointed out that we weren't clear who was going to get that communication, given that people couldn't access it, they quickly moved to posting the information on an opening screen on workstations. They were able to do that. And some follow-up communication, once everything was restored, was sent by email once the situation became more stable and people could receive that. The potential disruption to services was communicated to the public by our media team. We didn't get any requests for information from media following that, and also, interestingly, didn't receive any patient complaints or reports operationally that this was a concern. Again, I think that if this had gone on for a little longer, we would have, but it was good that we had communications looped in and we were ready to do what was necessary should there have been a problem. Next slide, the recovery. So our shared services team engaged a whole slew of folks to investigate the root cause, and then once it was identified, conduct system tests and validate the applications. This team was an extraordinarily deep team. We were really impressed by how they were able to pull resources together so quickly. However, they were working for 36 straight hours. After 24 hours, they began to rotate people and reduce that capacity. So that's something certainly to be mindful of. We were prepared for another occurrence, thankfully, once things got resolved. Information was provided by Microsoft, but thankfully the issue didn't return. And our digital shared services team conducted a technical major incident debriefing, and my team conducted a debriefing of the overall response. Both of these debriefings were documented and the information was shared internally. So, opportunities for improvement and mitigation. I've got 2 slides and then I think we're done. This is the good stuff. So communication obviously was challenged due to Outlook being affected. If all of our work world relies upon email and it goes down, how do things look for everyone? And it was very interesting to see the interplay between the different organizations who aren't in the same digital environment as, say, our provincial health department, where the health department relies upon all sorts of information from our side and couldn't see it, and vice versa, couldn't receive it. So, we're all one health system, and yet we're not when it comes to digital. We did, you know, we know that the communication needs to be improved by developing and employing a better communication strategy to be able to reach the intended audiences and have a more timely response. We're looking at reviewing our existing processes, including some forms and templates for distribution groups to be able to quickly get messaging out and accurately include all the information that they need. There's some preventative information that we could be doing by promoting a better understanding of the impacts that result from outages of digital applications. And I mentioned this earlier, there is the recommendation, and this is good for us that it's landing here, the adoption of a provincial emergency notification system with the appropriate resources to do that on a 24/7, 365 basis.
Karen, I'm just going to give Francesco a quick poke, recognizing that he's the one, I think, with the slide deck displaying that we might be behind a slide for you.
Okay, there you go. So I'll ask you to go to the next slide then, Francesco. Thank you for that, Misha. I appreciate the poke.
Sorry, I accidentally stopped sharing the screen. I hit escape one too many times. 1 second, let me fix this.
I believe you want slide 9 out of 10.
Perfect. Let me share again. Okay, there we go. Sorry about that.
No problem. Okay. Other opportunities for improvement and mitigation include developing standard operating procedures for those staff teams that were brought in to assist with backlog. Not just the staff teams that help digital health, but also what kind of protocol would a department need to be that's impacted by this outage to be able to then do the recovery afterwards. Clearly, there's a lot of charting that was paper-based that had to then be implemented in TPR, and right now we just don't have really a standard process for how people do that. They just kind of pull them from their regular duties and say, here's extra work and make it happen. Obviously, if this goes on and on, the more and more data, the harder that's going to be. There is definitely a concern for the length of time that some operations could maintain their procedures and continue to deliver service. We need to better align our RTOs with these downtime procedures. Right now, they're not congruous. They don't make sense. The recovery time objective, if it's exceeded, our recovery time objectives aren't matching the kind of actions that we're recommending. We need to develop a list of the impacts for every digital application that could be referenced in response time. So we were having to do a lot of educating and figuring out, okay, tell us what RIS is, tell us what this is, and updating these procedures as we go along. We've had a funding submission to hire a BCP specialist. It's under review right now, but this was an excellent example of the kind of work that a person with business continuity planning expertise would be able to, be working on and having that information available for everyone. And finally, Microsoft was able to bring forward some suggestions for ways that the digital environment can be configured. And I know that that's not emergency management per se, but things that, really were used and referenced by our digital teams, like run books, updating lessons learned, and all of that with the ICT teams helps to prepare them to be able to respond better next time. And that is it from me. The next slide just has my name and my contact info. If you're interested in reaching out, if you have any further questions, I'm happy to take them obviously today, or if later, that's fine too. Thank you.
That's fantastic. Thank you, Karen Denise. We appreciate you sharing this experience with us. One takeaway that I immediately had while you were joking about, almost it being slightly deflating to determine that it's not a cyber-related incident is the fact that when it's a cyber-related incident, you kind of have the boogeyman to point to, and the understanding that you don't have an estimated time for everything to be back up and operational when it's cyber related. So when it's not, it means those questions can come very quickly about how long before this is fixed. and you don't have a bad guy to point towards in these situations. So I don't see anything that had come up in the Q&A that was relevant to your chat, but I do see a couple of things in the chat that were asking about how long before you went to manual processes. So I can see this kind of, how long was the back charting considering it was a 36-hour range?
I don't know if my audio is still bad. My apologies if it's good. All right. So because the nature of this outage was that it wasn't just on or off, it was sometimes there and sometimes not. It took us until about 10 o'clock in the morning to make the decision that people should be instructed to go into downtime, because we were actually concerned that some people would think that they had access when maybe they didn't. So they would be using the application and then it wouldn't get saved. So we made the call, even though you might see that app up on your, station, it could go down right away. And most people were having so many problems. As more people tried to get into it, it would crash. So I don't know if that answers your question, but had it been an on or off, we would have asked people to go into downtime immediately. But because there was an investigation and it wasn't clear that it was consistently not available, there was a delay. So from 5 a.m. until 9 a.m., you could do the math. There was a few hours there. Thankfully, the home care clients are not necessarily, there's not a lot of night visits. So that was a blessing, that those first few hours might have been a little bit of a wash, a little neutral.
The individual who asked the question said that does answer what they were looking for, and obviously, commenting that intermittent loss can be very dangerous in itself. So just being respectful of time, because we have the next presentation, we can move along to that. And then obviously we'll still have some time for, kind of communal questions at the end of the session. So if you have something and you didn't put it in the Q&A yet for Karen Denise, please do that now before you lose it. And we'll try to get back to it in a little bit. So with that, I'm going to switch to introducing our next speakers. So I'll start with Andrea McCormick. Andrea is a registered nurse by background and started her career at Sick Kids Hospital in Toronto in the pediatric intensive care unit as a bedside nurse in 2007. And after finishing her Master of Nursing Administration at the University of Toronto in 2013, she started a role as a critical care quality team leader. And after several years in quality, she then served as an interim pediatric intensive care unit senior manager before starting in her current role as a senior manager in the Central Quality Management Department at Sick Kids. So in 2021, she took on the portfolio of emergency preparedness for the hospital, obviously during the pandemic, but we're not going to go there and talk about those challenges and taking on a role like that at that time. But Andrea is passionate about healthcare quality improvement and strategic project management, and brings that lens to her approach with the overhaul and renewal of the emergency preparedness program at Sick Kids. And pairing up with her today is Yvonne Howard. And Yvonne is an emergency department nurse by background. She's also a passionate educator with diverse experience as an education specialist in both clinical and corporate roles. She transitioned to the quality management team in 2022. Yvonne leads hospital-wide emergency preparedness projects such as the build and rollout of new active attacker policy, the development of color code and command center training exercises, and the revamp of many hospital-wide emergency preparedness resources. She's a credentialed associate simulation instructor and is excited to develop an emergency preparedness simulation program, which will, of course, include unplanned downtime readiness exercises. So with that, I can shift it over to you ladies to share your experience at Sick Kids with us.
Thank you so much. I will acknowledge that I'm using a business continuity backup myself by presenting from my car after an appointment ran very long this morning. So I will acknowledge that. That's pretty obvious. So there. Thank you so much for having us here today. We're going to talk about the cybersecurity attack that was well publicized that occurred at Sick Kids in 2022. Next slide. So what we'll do for you today is kind of set the stage. We will talk about the frontline impact, a little bit about our IMS structure at Sick Kids, the debriefing and the lessons learned since that event, and our next steps. Next slide. So let's set the stage. Go to the next slide. You can see just some clinical stuff. Really what we had at Sick Kids in terms of IMS and our responses is a virtual command center that had been in play for about 3 years now. And for a number of reasons we needed that, not only because of code gray downtimes, but we also had an EP team in 2021, which started as someone, one of our team members had retired, became me, and then has been growing since. And so now I can happily share that we have a 2.5 dedicated FTE in the organization. And we serve as an advisor role in the command center to help kind of like the oil in all the cogs to make things move forward. Next slide. So a little bit of understanding about code gray local to Sick Kids for infrastructure failure. It is our most common non-clinical code that occurs and necessitates a command center. We had 15 code grays in 2021 to 22. 10 of those were IT communications related. There are a lot of recommendations that came from these codes and indicated that we really need a separate code for IT communications and infrastructure itself that fails. So that is in development. And we do know that code gray can impact multiple systems and necessitate other codes being called, such as evacuation or fire. I'll just say generally, I think this is something that might be happening with a lot of hospitals is you have a lot of new software in buildings and exciting new software that is interfacing with old tech or old systems in the building. And so that is often where we find we are having these types of breakdowns in what's happening. But that's not what happened here. Next slide. Okay, so we can click this clip
and the
that
hospital
they
for
want
Sick
to put
Children
in.
says it's dealing with a cybersecurity incident that's affecting several network systems, including some of their phone lines.
Sick Kids says a system failure called the Code Gray went into effect on Sunday night, prompting the activation of the incident command center. The hospital says patient care is unaffected and there's no evidence that personal or health information has been impacted. Chopper 24 is above the hospital for us this morning, giving us that bird's eye view. Officials say third-party experts have now been called in to help resolve the situation.
Okay, so as you say, it was December 18th, a typical Sunday. But again, if anyone remembers what was happening in 2022 was a pediatric surge. So while it was a typical Sunday, it was anything but for our hospital. We were up against it from a staffing point of view, from a census and acuity point of view, and everyone was looking forward to some holidays. Next slide.
And the hospital for Sick Children.
So the first 24 hours. So I was not surprised to get a text message to say that we might need to call a VCC or call a code gray around 1800, and we did so at 2120 when it became evident that we were having some downtimes. The difference between the typical code gray and our virtual command center was our IMT team said, we need a little bit more time. We need a little bit more time versus usually they're very able to diagnose things. And we had that diagnosed officially to the VCC and our leadership at 3 a.m. as we reconvened throughout the night. We were able to, as we have a mass notification system, do a call to action for leaders to join at a 5:30 a.m. meeting. With a broader VCC and leader update occurring, and then doing an all staff at 6:30 a.m. to notify everybody of this event. In typical Sick Kids fashion, it becomes public very quickly, and our CEO was addressing that by the end of that day. Next slide. So I'm going to hand over to Yvonne, who's going to talk to us about the frontline impact.
Thanks, Andrea. Francesco, next slide, please. Okay, so what you're looking at is a dashboard that our IT team used to sort of create situational awareness within that VCC, which, as Misha put in the chat, actually stands for the Virtual Command Center. Okay, so this was our entire sort of incident management team that comes together on Microsoft Teams. And our IT team was sharing this dashboard with us. As you can see from the dashboard, this is actually a screen grab from partway through our recovery, but it gives you an idea of how many impacts there really were in the hospital. So there was a total of 114 critical, high, or sort of medium urgency services that were identified and impacted. There was 80 low and legacy urgency services that were also impacted. And so it just had a really widespread effect on so many parts of our operations as an organization. Next slide, Francesca. I would be remiss, however, if I didn't start by recognizing what did not go down. So our IT team, I'm not the best person to talk to about this. I'm not an IT expert by any means, neither is Andrea. But we need to suffice it to say that our IT team did an amazing job in that overnight period, that first 24 hours, with the help of some external contractors, to retain a couple of key systems. And one of them, very importantly, was our patient charting software. And that was a game changer. We also maintained access to Microsoft 365. So again, Microsoft Teams, so we could still have our command center online with each other, SharePoint, so we could push out a bunch of resources to staff that they could access from outside of the Sick Kids intranet, as well as our email. Our email is in our Office 365, so we were able to email staff. We also have a mass notification system called Everbridge, and Everbridge continued to work, and we could use it for all staff updates if needed. Next slide, please. But when that video clip said that there was no frontline impacts, that was a little bit premature, okay? So as it became clear just how widespread this attack was going to, how widespread of an effect this attack was, it became really clear that there was going to be a lot of impacts and that some of them would be quite long-term. So I divided these as frontline impacts into a couple of buckets of priority services. Bucket number one was payroll and finance, okay? This was December 18th. So we had payroll due that was supposed to go out December 23rd, right before the holidays. And it became really clear to us within a couple of days that we weren't going to be able to pay our staff accurately. Not so big an impact for people who are on auto pay, huge impact for all of the frontline staff at a hospital who do shift work. So that was significant. And the second group is our scheduling, some of our like on-call and standing scheduling software. A lot of that went down, and it became clear that a lot of areas did not have a hard copy backup. So staff didn't know, or managers didn't know who was scheduled, who was working some days. And again, we're going into the staff holiday schedule. So that, again, very significant risk for those areas. Not next slide. The next bucket was around systems that interface with each other for patient care. So our Epic, our charting software didn't go down, but a lot of our critical diagnostic systems couldn't interface with that. So that means a lot of our areas, including diagnostic imaging, our lab, our blood bank, had to fall back onto manual processes and manual updates into the patient chart. And so that was very laborious and slowed down a lot of our processes. Finally, is what I'm calling sort of our safety backup. So things like our policy and procedure database. We had a downtime plan for policies and procedures, but it was not a very easy to navigate backup for our frontline. And policies and procedures are something that, no one likes having to wade through them, but so high risk when they're not available easily. As well as things like our safety reporting system, which we actually really rely on for our frontline staff to tell us what wasn't working. So that sort of channel of communication to our VCC was impaired. And being a pediatric hospital, we have a lot of online tools that our staff use as a safety check. Things like drug calculators and resus drug calculators that we do based on weight, and infusion calculators, so we can, again, base infusion rates on weight, and those things became unavailable. So that is was a real sort of safety impact for our frontline. Next slide, please. Thank you. This was a social media post from one of our ICU nurses, which made us laugh out loud, but also highlights a vulnerability that actually Karen referenced in her presentation, or some of you have referenced in the chat, and that is about how we have a lot of young staff who are not used to paper charting. And so we had told all of our areas to prepare for downtime because we weren't sure how this was going to progress over those first few days. And it became really clear that in a lot of clinical areas, our frontline staff do not feel equipped to go to prolonged downtime paper charting, because that is just a skill set that's being lost. So that really highlighted that for us. Next slide, please. Thank you. This is another photo that our team took that we laughed about, but again, what we want to do is highlight the teamwork and resilience and give kudos to the teams in our hospital, because as in many emergency response scenarios, staff such as this friend of ours on the floor were asked to do atypical tasks in unfamiliar settings. They were asked to do a lot of problem solving and creative workarounds and laborious manual processes, and asked to have so much patience. And it was in the midst of that brutal viral surge of fall 2022 that Andrea mentioned already. And we had just been working in this unprecedented surge management scenario in the whole province when it came to pediatric, especially intensive care. And so this was sort of insult to injury. But our teams rallied and they supported each other. And for the most part, all of the feedback we heard was that teams were really proud of how they pulled together. And it was in the sort of face of that common enemy, which I know Karen didn't have, but we really did have. And it became clear the ransomware company even came out and apologized to sick kids, which is unheard of. But it was very clear external to the hospital. And I think that helped with the staff morale during all of this. Next slide, please. Okay, Andrew.
So we did conduct after the event. It was about, I'm going to say, at least 2 weeks in duration before we were able to call it off over the holidays around January 6th or 7th, where we had a majority of systems back online. We did conduct an all-staff Microsoft Forms survey afterwards to hear more about people's experiences, what worked well, what didn't, what tools reached them the best was really, really key. We did ask local leaders to do debriefing with their team, and then also our command center did a debrief of this event themselves to understand how we might address it differently or how we might improve. Next slide. Okay, lessons learned. So in terms of lessons learned, we really, this is for all major codes that affect an institution, but having that rapid dissemination of best information possible to relevant teams as early as possible, and not striving for perfect communication. So getting it out as much as possible. Lesson 2 was that leadership presence and transparency was key to confidence. So having people on site, having people there to ask any questions. And then lesson 3 really was identifying all those ways we can reach out to staff. We did use our mass notification tool to notify all staff on a few occasions, mostly related to pay. But I'm just going to say, if your staff are not used to receiving something from a mass notification tool and they're under a cyber attack, they might think someone contacting them about their pay is a hack. So that did happen. That's okay. It was a great learning experience, however terrifying at the moment for all of us. Next slide. For lesson 4, it's really having that centralized storage of ad hoc documents, our guidelines, our process and workarounds for future codes, because we learned so much during this event. And then that local area expertise is very key, and it is part of what we're looking at in these upcoming accreditation standards. Creating redundancy in legacy systems so that there's not 1 or 2 people who understand how these things work. And then also these key operational systems need to have a lot of extra redundancy, and then create this communication pathway for when we use the mass notification system and a policy of how we use it, because we were kind of creating that on the fly. Next slide. And I'll hand over to Yvonne.
Okay, I realize we only have a couple of minutes left, so I won't go into these last slides in detail. This says next steps, but what it really is ongoing work, because we are quite a ways out of this now. Around policies and procedures, ongoing work has included, we are going to be one of those areas that splits our code gray into two, because we learned through this that IT and communication outage is quite different than all the other infrastructure failures, and we want to represent that in our policies. We are working on that mass notification policy that Andrea referenced. We are using simulation to test all of our new policies, and that will include our code gray, so that our frontline is involved in building the policy from the beginning. And we also have made a lot of accessibility improvements for our PNP database, knowing just how critical they are in these sorts of scenarios. Next steps, or next slide. Downtime readiness. We have learned how much work we need to do on downtime readiness, from anything from updating our departmental emergency preparedness plans to reflect like an attestation to a certain level of downtime readiness to keep it on the radar for managers. Also things like standardizing management of our downtime documents, because we found they were scattered all over the hospital and we need a central way to find them. Things like keeping a hold of all those workarounds that were developed so amazingly during this code gray, so we don't lose that knowledge that we gained. And integrating downtime into a lot of our hospital-wide EP simulation and education strategies. Final slide. And then things like hiring more people to do EP, because we realized how many hands we need when needed. And we got, I know, so we have a new member of our team, updating our business continuity plan, migrating more resources onto that SharePoint 365, because it was a resilient, obviously only the things that are safe to have in the cloud, but stuff that is key for staff to be able to access no matter what's going on with the intranet, and just involvement in campus redevelopment and more education and cybersecurity awareness across the hospital. I believe that is our last slide. Try one more, Francesca. That's it. Does anybody have any questions?
So I realized you guys just flew through. I think I'm a fast talker. I've met my equals with this for being able to just flow and go. What I have right now, before I jump in the Q&A, is a huge heap of gratitude that I want to extend to you for being able to come here and talk about a cyber-related response, recognizing that for everybody that's still on the line, we wanted to have more individuals take part in this session because we know how important this is, this loss of network. And a lot of organizations just dealing with the legalities and the privacy concerns around cyber incidents didn't feel comfortable being able to come and share with us today. So really grateful that Sick Kids was able to come and give this really fulsome overview of everything they went through and their key takeaways for us. So thank you very much for that, both of you. There was a question that came up in the chat that was kind of asking about, and I don't know if there were additional takeaways that came out around this, which were any of the additional steps that could be taken to avoid security breaches. I'm not sure if you're even able to talk about any of the specifics for your organization for the reasons that I just disclosed. I don't know if there's any commentary that you might have on that point to share, but it's open to you.
I can share that we had done significant work prior to this event and run tabletop sims with collaboration with our IMT team and some external partners that had already been engaged, because we had at the time a very competent lead for our IMT security who was poached by the states, so that's not surprising. But he laid the groundwork, so we were able to do sims on this, and our IMT team, as more importantly, had done some sims on this and had some protocols in place, which was key, as I mentioned, to saving Epic and these other cloud-based things from being compromised. So I would say, yes, there are things that you can do that your IMT team can get plugged into with external providers to do that. And to map out their processes. And this is what our IMT team had done. And our EP team had been involved in those initial exercises. Yeah.
No, that's great insight. Sorry, go ahead, Yvonne. I think maybe you're about to say something.
Sorry, I should have put my hand up. I will just add to that. Another thing that has happened that our IT team has increased frequency of after that is just that general cybersecurity education. So we have that sort of yearly e-learning that everybody does, but they also have started sending out like intentional phishing emails. And if you, I think a lot of organizations are doing that now. And if you catch it, then you get like a congratulatory email. And it's very funny, but our team was just joking yesterday about how satisfying it is when you catch one. So even just those like tiny little interventions, I think actually are really has made a lot of staff think about the emails before they open them. We don't know if that was related to what happened, but we do know that in general, the statistics show that phishing emails are actually like a way into a lot of organizations. So even little interventions like that can be really effective.
No, thank you. I think, Yvonne, Andrea, you captured some of those strategies from like frontline, the front computer user all the way up through the organization. So I think that's valuable feedback. Thank you. Somebody did also comment that they appreciated your responses because it made them feel better that something can actually be done. So just want to note that. Somebody did point out, I'll just take maybe one more question here, recognizing again, we're kind of over a little bit, is somebody was asking how was the communication handled externally to other hospitals for your response. I mean, Karen Denise was able to provide sort of a provincial overview of how their communications worked, but certainly for yourself as an acute care facility, was there a plan in place? Were there redirections happening? Any sort of additional insight on that piece?
Yeah, I mean, CK doesn't really go on redirect. We haven't really ever done that. We don't have a close by equivalent for a lot of the tertiary and quaternary care. So while we might say something like, if you're not having a big issue, please go to a community hospital, we don't really do that. Our ICU serves I can't remember the percentage of PICU beds for the hospital, for the province, but it's a large chunk. So we don't typically do that. I've never seen that. But I would say the communication was standard, as we would use, the things we have, EMCT tickets throughout the province that we used, and we updated that throughout the event. But our public affairs and comms was obviously lockstep with our board and our executive and our legal to make sure that what we were putting out there made sense. But as we all know, when something happens with sick kids, it's public right away. So we kind of acknowledge that from the jump. And yeah, and I think you'll never really know. I mean, there's a huge fear. It was my biggest fear. It was on one of my lists. It was one on my list that I was like, okay, as long as this doesn't happen this year, it doesn't matter. And okay, it happened this year. And even so, you will be surprised at how well people are able to pull together and make it work. And I was just very thankful, and I think Yvonne would echo this too, for the existing work that had already happened. So I would say that that is key for your IMT teams.
Okay, excellent. Thank you very much. So I think I'm probably at the point where I know we have a couple of straggler questions. I do want to say to those of you that have managed to stick around that if you have additional questions, we'll get an email contact for you. So that way you can get the questions to us and we can do our best to address those questions after the conclusion of this session. So especially if something comes to you and you think about it and you'd like to get that answer, please reach out to us. So I want to give, again, heartfelt thank you to Karen Denise and Andrea and Yvonne for sharing their experiences, hopefully by providing this opportunity to attendees to think about network loss from, a hardware, a software issue, right up to having some sort of cyber incident. Losing that network has a major impact on safe hospital and facility operations. So very, very grateful for you sharing all of your lessons learned so that hopefully we can turn them into lessons applied. And with that, I'll turn it over to Francesco to do kind of our final closeout for the session.
Hi, thank you. Yeah, just to echo my thanks. Thank you so much, Karen, Yvonne, Andrea, for presenting today. They were great presentations. Really learned a lot, as I'm sure the audience did as well. And thank you, Misha, for moderating and for your collaboration for helping put together this great session and this great panel of speakers. And of course, thank you to everyone who came and attended and who was able to stick around a little late. Oh, sorry, I just realized my microphone was up, so I hope you were still able to hear me. But yeah, thank you so much to everybody for joining us for the first session in this 2024 series. So just as a reminder to everybody, or to those of you who are new to the series, we had 6 sessions in 2023, and we're doing another 6 sessions at least in 2024. And they're monthly series, so they will be the first Wednesday of every month. And so registrations are open for those of you who registered for the original series. It's the same registration, so you don't have to worry about it. But feel free to share it if within your networks, if you know anybody else who might be interested in joining. So yeah, just with that, I'd just like to thank everybody one last time, and also thank you to Thunder Bay Regional Health Sciences Center for becoming a partner on this series with us for the 2024 sessions. So yeah, that yeah, thank you very much.